only for very limited cases where you have dense scarring and you want to have cyclodialysis. So this technique is just an innovation. It requires further validation with studies from other surgeons, but it's a good thing to have in your armamentarium, and you just create a 1 clock hour of cyclodialysis. Now, there is a lot of interest in anti-VEGF agents. So the common question asked is that should we augment trabeculectomy with anti-VEGF agents? And the answer is a big no, as you can see from this meta-analysis. If you combine anti-VEGF agents with trabeculectomy versus a mitomycin C, so there is no benefit of combining an anti-metabolite because it has a short-term effect. This is only useful if there is a rubeosis iridis or you are using it for neovascular glaucoma. For a routine trabeculectomy, mitomycin C should be used to prevent fibrosis. Anti-VEGFs are not useful for in this regard, and the long-term outcomes are not useful. The other thing was we also had for some time this implant available, Ologen implant, and this was advocated as a replacement to trabeculectomy to augment it. But histopath studies showed that there is a dense fibrosis within the implant, so it is not at all useful. And in fact, we tried to use it in addition to mitomycin C, and you can see the type of blebs we used to get a ring of steel around the Ologen. So we have stopped using these Ologen implants. So in my opinion, there is no benefit of adding these collagen implants to trabeculectomy, even if you are using mitomycin C. So mitomycin C trabeculectomy remains the gold standard. The next important question is that often there is a confusion. Patients are referred to you who have got both a cataract as well as they have got glaucoma. So should we do your trabeculectomy before or after the phacoemulsification? So this is a common issue, and I think there should be very clarity on this. The sequence of trab followed by phaco is not a good option. You should do phaco first and trab afterwards. That is because when you do phacoemulsification, there is a increased inflammation and your trabeculectomy bleb fails. So cataract surgery has the tendency to compromise IOP even when you have a temporal phaco and a superior bleb. So if you see the cataract, it reduces the bleb function due to upregulation of the fibrogenic cytokines and increase in the conjunctival fibroblasts. So they found that the sequence, if you do trap first followed by phaco, that has worse outcomes as compared to doing a phaco first followed by trap. So ideally, if you have both the diseases, you do the phacoemulsification, wait for at least 6 months to 1 year so that the blood aqueous barrier is healed, and then subsequently you do a trabeculectomy, which is much easier in a pseudophakic eye. And another thing which is very important, you have done a very good trabeculectomy and patient comes back with high IOP, and that is because we have this tendency to stop steroids at an early stage. And that is something we should never do. The post-operative steroid on a tapering should continue at least 3 months after trabeculectomy surgery, and you should taper it off. And if you find that there is vascularization of the bleb occurring, then even you can augment systemic steroids, because this is the main reason why your trabeculectomy fails if you are not monitoring the post-operative healing response of the patient. And finally, I think why you are scared of trabeculectomy is this complication that you will end up with blebitis and endophthalmitis. So it's very important to counsel the patient about the risk and the symptoms of this complication. And if any time in the post-operative period you detect a bleb leak or patient develop blepharitis or is using any form of dry eye therapy, you must counsel the patient about the risk. And if you detect any bleb leak, immediately that has to be repaired to decrease the blebitis and endophthalmitis. And we have found success in early bleb leaks with the use of doxycycline. So this is a conservative therapy that can be used in the early postoperative period to manage bleb leaks without doing any surgical intervention. And just finally, one small tip about trabeculectomy, that when you make a trabeculectomy flap, so this we are all used to. So the main thing I have learned over the years is never cut it to the limbus. So you can see what the So trabeculectomy flap has been made, but only 50% has been cut. So that on both sides, this tissue remains. And I think that is a very important factor, that this and this side is not cut. That prevents the post-operative shallowing and leak from this area. So this is a very important thing. Never cut the trabeculectomy flap up to the limbus. So I think that is all I wanted to cover. Thank you very much for your kind attention.
Thank you so much, Dr. Tanuj. I don't know about others, but I'm definitely going to hear this talk all over again. It was such lovely, lovely tips you gave, so practical and so easy and relevant. But talking about that deep, small punch of scleral tissue which you remove from the scleral bed, would you keep it only for special cases, or do you believe it should be done in all routine cases?
See, actually, if you're dealing with juvenile glaucoma or young patient, the sclera is very thin, then this is not possible.
Hmm.
But if you're dealing with cases which are advanced, which have got uh, like a field defect less than 10 degree, or where you require low target IOP, then this technique is very useful. So 50% you make an initial depth and then you make a small crater. So we have been using it for lot of our cases because we get referral of advanced cases. So as a routine, we have been using, and it gives a very good long-term outcome. The only thing is there is a risk of overfiltration. So the edges of this deep stacking should not overlap with the flap. It has to be narrower. If it overlaps, then it causes overfiltration. And what we do at the end of surgery, we apply trypan blue and see if there is any area of excess, that in you have to apply an extra suture. Otherwise, it's a very good technique for increasing outcomes. And trabeculectomy is a one-time surgery. So this modification increases long-term success without reducing the complications.
Oh, thanks a lot. Dr. Sunita, I wanted to ask you, and I'm sure I would want Dr. Tanu's thoughts on that too. What are your thoughts about using injection mitomycin versus sponges? Like, people who are using sponges should give up on it, or both of them are nearly parallel in their long-term outcomes?
So, there are several studies which suggest that using injection in long run is more beneficial because you're using a more titrated dose. And also the bleb form is more diffuse. Unless you ensure that you use sponges very posteriorly, so as to form a very diffuse bleb. But there are studies which also suggest that the amount of mitomycin C delivered with these sponges vary a lot. Like if you use 0.2 milligram per ml, so the concentration of the MMC which is delivered ranges from 0.7 to 17 micrograms. So there is a large variation of the dose delivered. But still, despite knowing that, I've been using sponges only in my trabeculectomy, and I am getting good results. So although theoretically injectable MMC is better because you can titrate better, but practically I found not much difference between the two. But when I'm doing needling, I use injectable 0.1 milligram per ml. So theoretically, there are papers which suggest it is good, but I don't think we have long-term data, Indian data, to suggest that.
Dr. Tanuj, Dr. Pandav, and Dr. Gauri, just two lines for your thoughts on this.
Yeah, I agree with Dr. Sunita. Like the injectable, there is also this limitation that you need to give the injection, wait half an hour, and then proceed with the surgery. So there is this logistics also, which you need to factor in. You can also standardize the amount that you deliver by keeping your Vexel sponge pieces of a uniform size and keeping, say, always standardize saying 4 swabs I'm going to keep in posteriorly. So your own method, you can standardize it. It will not be down to the micron level the same, but at least it will not be too variable. Dr. Tanuj, I wanted to ask you more about that cyclodialysis that you were talking about. So we all know that cyclodialysis, when we do it or when it inadvertently happens in a trauma, the eye pressures tend to come very low, and suddenly at some point of time the cleft closes and the pressure shoots up. Okay, so there is this degree of unpredictability which is associated with cyclodialysis. what is your experience with regarding to this when you have used this to augment the trabeculectomy as you showed in your talk?
So first thing is this is not for general viewer. So
Okay.
it is only for very specialized glaucoma surgeons. So this is just an innovation side. Like you have this MIGS, you have all these new implants coming, which are inserted between the ciliary body and sclera. So they function by causing a localized cyclodialysis.
Yes.
So what we found was this is only very limited when there is dense scarring like post-vitectomy cases.
Okay.
So we make a 1 clock hour cyclodialysis. But what we found was it used to close down definitely due to fibrosis. So there we use this small scleral tissue, patient's own sclera, as a sort of stent so that
Mm-hmm.
the cyclodialysis does not close. So it functioned well, but we have hardly done, I think, 4 to 5 patients
Mm-hmm.
over the last 10 years. So I
Mm-hmm.
think it's a technique which requires further innovation and exploration. It is definitely one of the tenants available, and I think this the route of this cyclodialysis must be explored because now we are getting lot of glaucoma drainage devices which are being placed in
Mm.
the ciliary body.
Suprachoroidal space. Yes.
Yeah, so I think this is something we have not explored.
True. True.
So I just wanted to introduce this concept, but at this moment, I don't think anybody should take it down into the operation theater. It will require further refinement.
Yeah. Thank you, Dr. Tanuj.
Dr. Murli, any questions? Murli, you're muted. Unmute yourself.
So, would you say there is a continued role for 5-fluorouracil in the postoperative period, especially when the bleb is angry looking, or would you rather give mitomycin injections or drops?
No, Murli, I think there is definitely role of 5-fluorouracil, and if you get a encysted bleb or angry looking bleb, then you can inject 5-fluorouracil, and always you have to take care that you are coating the cornea with viscoelastic so that if it doesn't touch the cornea, that causes a very toxic epitheliopathy. But definitely, if you have early scarring, then 5-fluorouracil can be used. If you have late postoperative, very dense scarring with more risk factors, then mitomycin C can be used. And when you use mitomycin C, it is better that you first inject some viscoelastic like Hilon and then inject mitomycin C. So that way it spreads in a uniform manner and the mitomycin C doesn't spurt out of the injection site. So the effect is slightly uniform and tamponaded. So both options are there. For early cases, 5-fluorouracil we use because already we have used mitomycin C. And if you do mitomycin C again, then the side effects come maybe 5-10 years later, then you get a very bad thinning of the bleb. So 5-FU is definitely safer.
Yes. Thank you very much. Anything else, Dr. Pandav, you would like to add on this very interesting talk of Dr. Tanuj?
Yeah, Dr. Tanuj, I think thank you. That was an excellent talk. I think you covered a lot of things and introduced new concepts as well. The only thing about we are on mitomycin C, so I agree with Tanuj and Sunita the way the MMC is used both like on sponge or through an injection. What sometimes I do is I don't inject it on table because sometimes injecting on table means that you have already given the mitomycin, and if there's something happens in the post-operative period, you have buttonhole, or if some reason you find the tissue is fragile and you didn't want to use mitomycin, then actually you can't go back. So sometimes I use actually in the post-operative period. So I don't use any anti-fibrosis on table. You wait for say about 3 days on an average, 3 to 5 days, depending on how the wound heals, and then you can give actually in the post-operative period uh, by injection like 0.01 milligram per ml. Now the advantage is that it actually now it starts acting when you want it to act, because when you give it on table you are doing a pan, but mitomycin is actually very strong drug, so it gives you the pan inhibition of all the healing processes. You actually want some healing to happen for the first 2 days at least. So we have actually compiled our data. Initially, I was a little conservative and I was using like 7 to 14 days around that time frame. But I think now I have shifted the time frame to somewhere in the 5 to 7 days in the post-operative period. So I have compiled the data. I think hopefully you will see sometime in the journals. But again, this is a new thing, so you can't really recommend for everybody. But our results are this like as good as on table. With the advantage that you can decide whether you want to give MMC or you want to use 5-fluorouracil, or you don't want to go, you don't want to give any antifibrosis. Sometimes you don't need any antifibrosis. So that option actually remains with you even in the post-operative period. So I think that's something little new, and but otherwise, I think what Tanuj has said, that's fantastic. I think most of us are actually using mitomycin C on sponges, even though I think there are advantages of using as injections as well.
Thank
And
you very much.
one, yeah.
Yes, doctor. Yes, sorry.
Yeah, and the one thing for Tanuj, or just a comment, because are you using that the irrigation, cannula during trabeculectomy, like AC maintainer, or because when I use a few times, if the iris is floppy, it actually goes into your the fistula site, and creates problem. So I kind of avoid using that. So just maintain your AC as far as possible by injecting through the side port rather than have irrigating cannula. But I think kind of it is recommended in literature, and many people, I'm sure, use it. But I don't know what Tanuj's experience is in cases where you have a floppy iris, or it's kind of tries to flows into that fistula that we have created.
Yeah, I think this is just an option which is available, and
Mm.
especially where you are expecting a hemorrhage complication like Serge Weber. So other cases, I don't routinely use it, only for specialized cases. But nowadays, in these high risk cases, I prefer to inject some Helon in the AC, because we have had some recently,
Yeah.
some pediatric subconjunctival hemorrhages. We had 2, 3 in a row. And that lady scared me. So before entering the AC, we just put some Helon and let that stay in the post-operative period. So you can sleep peacefully the next day.
Yeah,
Wonder,
sometime I
if I
leave
may
it
add,
on. Yeah, sometime I leave it on, but yeah, a few times it could lead to high pressure because we have a tendency to suture like tightly, and then if the Helon is there, then you could have a high pressure. So do you give something in the early post-operative period to compensate for that, or
So
if
usually?
I may
yeah.
add one point with that AC maintainer, I'm sorry to interrupt, is that yes, I would use it when I'm doing trab on a vitrectomized eye. So these eyes, once you do the trab and the internal ostium, they become very soft because the gel vitreous is not there. So having an AC maintainer helps you to suture the scleral flap, to titrate the amount of filtration, and to even suture the conjunctiva. You have a firm globe. So that is the only situation where I would definitely use an AC maintainer. The rest of the cases, as you said, Dr. Pandav, it is more of a hindrance than a help. Sorry.
Yeah.
Thank you.
Thank you. Thank you very much. I think we have to move on, and Dr. Tanuj, do stay on with us. Because we will come out the best pearls possible. We are very lucky to have joining us and taking us Dr. forward is Dr. Davinder Grover. And we all know he's a world-renowned glaucomatologist, and I've been very, very lucky to have him in many of my glaucoma webinars when I was chairperson ARC. And he's part of the Glaucoma Associates of Texas, Dallas, and is an expert in the medical and the surgical management of glaucoma. And he is going to talk to us back to back on two very relevant topics of the day. That's what's new and important in MIGS. And that would be followed up with his the next talk, which would be what has changed in glaucoma drainage devices. Really, really nice to see you, Dr. Davinder. So let's hear from you. Thank you.
Well, good evening over there. Good morning from Dallas. Dr. Chitra, thank you. So good to see you again, and so good to see so many wonderful familiar faces. Yes, let's get started. And what I'm going to start with is what's new with MIGS. And I tried to do something a little different here because there's not really, I mean, there's always something new coming up, but there's hasn't been anything revolutionary, I think, in the MIG space that's come out that's really changed the game. But what I think has really changed is kind of what our perspectives on MIGs should be, and how we think about MIGs, how we use them, and why what this idea is with MIGs and early intervention. I do work with a lot of the companies, but these are really not pertinent to today's talk. I will start off just with some brief basics for those that have never done MIGs or are still kind of entering into this space. And then I really want to have a discussion on kind of this idea of what is refractory glaucoma, what is interventional glaucoma, and how do we think about success with MIGs? That's, to me, I think is where we need a lot of help and a lot of innovation. So, in order to do angle surgery, you need to understand the angle, and you need to understand angle anatomy. And the only way to understand angle anatomy is to perform gonioscopy. And this is intraoperative gonioscopy, but more importantly, clinical gonioscopy. And so, I probably use a gonioprism 30 to 40 times a day in my clinic. I never hesitate to look at the angle preoperatively and postoperatively. And studying the angle and understanding normal and abnormal angles gives you an appreciation for all the normal variations. The best way to introduce intraoperative gonioscopy is just after a normal phaco. Just put on a gonioprism, tilt the head, tilt the scope, and look. And then just put a second instrument in the eye and kind of get that sense of that tactile feedback. Do all that before you even attempt to do any kind of MIGs. And then when you do perform your first MIGs, you can do things like a tenedo goniotomy or a hemi-GAT or things like that or a KDB, things that don't require a tremendous skill set before you try to do things like a 360 GAT. I like this picture. It shows a couple of things, right? You can see that there's a water stain on my gonioprism, which is not good. That messes up your view. When my assistant hands me the gonioprism, she puts on Helon on the bottom, and you can see I have Helon on the cornea. That helps really optimize your view. My incision for a GAT, I have not hit any blood vessels, so there's no bleeding, which is really nice. But remember, this is microsurgery. You need to be gentle. There should be no sudden, strong, or bold movements. And you need to always maintain your view. You need to always maintain your anterior chamber. If you can't see, you can't do the surgery. And this is true with all anterior segment surgery. The best way to avoid complications is to always maintain your anterior chamber. If you lose your anterior chamber, that's when you're going to be at risk of all the complications. The big difference between these two views is not maintaining my anterior chamber, and also I perform all my surgeries with my patients in reverse Trendelenburg. This is true with my phacos, this is true with my trabs, this is true with my Zens, this is true with my tubes. Anytime I'm operating on an eye, I have my patient in reverse Trendelenburg. That just minimizes the episcleral venous pressure and minimizes your risk of a choroidal event. And this, it's important to always stay comfortable. This is kind of how you should be. Shoulders down, sitting up straight. You don't want to be hunched over. You want to have your arms rested on the patient so you're in a comfortable position before you even attempt to do anything MIG space. And this is also really, the last talk was talking about the cyclodialysis clefts, either advertent or inadvertent. This is really a way to avoid an inadvertent cyclodialysis cleft, all right? So when you're looking at the angle on FOSS, looking at straight away, if you go straight through and you end up going too far, you're going to hit the back wall of Schlemm's canal. If you're looking from above and you go straight through, you're going to create a cyclodialysis cleft. So it's very subtle, but you want to make sure you're looking at the angle from kind of an on-FOSS, a head-on view. You don't want to be looking from above, and it's very subtle, but it takes time, and you really need to work on making sure you see the entire thing, and that's the way to avoid complications. What is refractory glaucoma? So in the United States, the FDA has some very specific definitions. Usually it was patient has to be on max medical therapy, has to have prior surgery. Sometimes they define it as prior incisional surgery. Sometimes they define it as prior, trabeculoplasty. But it's typically been these very advanced states where you've tried everything, and they've either had to be on all drops or failed drops. But is that really refractory glaucoma? just because a patient can tolerate their 4 drops, but they can't use them because they can't afford them. Is that refractory? What if their job is so busy that they don't have the time to, or the ability, the control over their job to leave to put drops on, or their life is so busy that the last thing they need to worry about, they're worried about their next meal and paying their rent. They're not worried about being able to put an eye drop in their eye. And so we don't really take into consideration a lot of these other components to kind of what refractory should be. What if they live in a small village and they can't have access to storing the medications, or it's extremely hot and they don't have a way to keep the temperature controlled of their medication, and then their medication gets damaged with temperature. So there's so many other aspects, and anybody that's ever had a loved one or has to take medication on a regular basis realizes that how hard it is to do anything once a day or twice a day, let alone 3 times a day, especially eye drops. It's just not easy. And this idea of interventional glaucoma is really the reason why we're getting into that is my personal bias is that glaucoma is a surgical disease. Now, that was hard to argue when the only answer was trab, tube, diode, or cyclo, or cryotherapy, right? And but now we aren't relegated to just trab, tube, diode. There are a lot of interventions we can do that are safer, less invasive, that have a decent chance of success, and allows us to then say, hey, we don't need to put a patient on drops for 30 years and have them have 5 surgeries before we do anything big. We can intervene sooner because our interventions are safer, and not everybody needs to get a trabeculectomy. But it's not just the theoretical component of, okay, are these drops, can they use them? They're not doing the drops. They can't afford the drops. But what is it about these drops? Are these drops safe? Is there a risk to using drops? And that's something that we're not really talking about a lot, is drops are not without risk. In addition to the cosmetic problems, the cost problems, there's something else these drops are doing. And if we look at the LIGHT trial, why did the SLT group do so much better than the latanoprost group? Why did they need fewer surgeries? Why were they less likely to need cataract surgery? Why were they less likely to need glaucoma surgery? Were the drops doing something to the eye to cause inflammation that is harmful? And this is, as far as what's new, this is something that I witnessed actually the first time I came to India to do GAT. So in our 2-year GAT data, when we reported it, we noticed that patients in the United States with advanced glaucoma, with a mean deviation of worse than -15, 90% of them failed at 6 months, oftentimes from not being able to control their pressures that well. And but a lot of them needed surgery to get down to the low teens. And so I think it was maybe 2015 or something like that, the first time I came to India to do GAT. The patients they had lined up for me to do GAT, all of them had mean deviations of -15, -20. They were the most advanced cases, and I was like, oh my goodness, this is going to be horrible. They're going to think this surgery doesn't work, because we know in the United States, these advanced stages of glaucoma, they don't do well with angle surgery. But these are the patients they had arranged for me. And but what's interesting, and as you know way better than I do, in India and in a lot of other countries, patients, it's not like in the United States where patients are put on drops for 20 years. Oftentimes patients present with very advanced glaucoma in eyes that are virgin, that have been untouched, that have never been on drops. And they're presenting for the first time with very advanced glaucoma. And what happened, and these are the patients that I operated on. And what I noticed was that their eyes were different than the advanced glaucoma patients that we take care of in the United States that have been on drops for 20 years. Their conjunctiva was mobile and fluffy and healthy. Their trabecular meshwork was springy when you touched it. It moved. It wasn't this sclerotic. The Schlemm's canal was nice and open. It wasn't fibrosed. And when I made my initial goniotomy, you could see the movement in the trabecular meshwork. It still looked healthy. And the patients did really well. And I was shocked. And it was the first time I realized, I was like, wait a minute, these drops are doing something. And then, you know, what's nice is this is a study out of Japan that came out a couple years ago that in a proper way evaluated just that. This was a tenedo goniotomy. And what they did was they took 146 patients that underwent tenedo microabdominal trabeculotomy, and they had the pretty standard definitions of success. And what did they look at? And what did they find? I mean, at 1 year, they found that patients that were using anti-glaucoma medications for over 4.5 years had a 50% chance of success, whereas patients that had been on drops for a shorter period of time had a much greater chance of success. So why is that? You know, we think that the drops that we use are without side effect, but anybody that has seen these kind of reactions and seen what prostaglandin orbitopathy does, it's not just the periorbital tissue that it's affecting. It's the subconjunctival space. It's the collector channels. It's Schlemm's canal. It's the trabecular meshwork. It's the whole inflammatory environment in the eye. These aren't benign, and we're doing these to our patients. And I think this is if we have options that are safer, drops, I think we can see are no longer sometimes the best option. So I think it is important to consider, you know, early intervention when it's appropriate. I think it's extremely important, and I don't have this listed here, it's extremely important for us to consider the cost-effective implications of a lot of these MIGs. Right, in the US, is it appropriate for people to be doing, you know, a stent that lowers the pressure by 1 or 2 points and costs $1,600? No, that's not even compatible with the US healthcare system, let alone the healthcare system in India. So are there cost-effective, reusable things like GAT, like the Tenedo blade that are successful, effective, cost-effective, and safe? And I think that's true. And so I think early intervention is important. I think minimizing our patients' dependence on drops is important. And our overall goal is to prevent, you know, the progression of this chronic, lifelong optic neuropathy. And our goal for our patients, my goal for my patients, I'm sure everybody on this call, the goal for our patients is to make sure they maintain functional vision for the rest of their life. And I want them to be seeing as long as they're alive. And that might be in 5 years, that might be in 35 years. But it's a long game and a long battle. I think how we define success is so antiquated. The way we define success with trabeculectomy, the way the FDA defines success is what every study does. IOP less than 21 or a 20% reduction on baseline IOP on the same or fewer medications without surgery, without losing vision. But what does that mean? And that's missing such a unique component. If I have a patient, here's an example, and I see this all the time because I'll operate on a patient with a pressure of 16 on 4 medications in a heartbeat if they have a visually significant cataract. I don't think that's reasonable to have someone have a pressure of 16 on 4 meds. That's just not, they're not doing their drops, and we know that. But if I take a patient with a pressure of 16 on 4 medications, and then I do a surgery on them, an angle surgery, and I get them down to 14, and they're on 1 medication. To me, that is a huge, huge clinical success, right? Pressure of 14 on 1 med, that's amazing. But you look at the definition, the FDA would consider that a failure. That's not a failure. That's a major clinical success. If I could do that every day, my life would be so much easier, right? So, but we're missing that. We're missing that opportunity to capture this type of patient as a success in clinical trials. And so we need a new definition of what success is. And you look at the European Glaucoma Society, and they have a whole pamphlet, 127 pages on recommendations for clinical trials, especially with MIGS. And they recommend, okay, let's show Kaplan-Meier curves of pressures of patients that were under 21, under 18, under 15, under 12. That doesn't capture people that has a starting pressure of 16, right? And it doesn't have medications. They tell you report your medications, but it doesn't have medication dependence in their success algorithm, which is such a big, big failure. This just recently came out in ophthalmology in 2025. Again, they're trying to capture that, but does it really capture it? They're saying this is a committee, this is a consensus statement. A lot of these are my colleagues and mentors, but they're not the biggest MIGS users. And they say, okay, well, the committee decides that standalone MIGS, if you're just doing a standalone MIGS, success should be 21 or less and reduced by 20% or more from baseline without an increase in meds. Again, that patient 16 on 4 meds down to 14 on 1 med, that'd be a failure still. All right. And again, I don't want to put the patient back on 4 meds so that I can get them from 16 down to 10, just to show that it's a statistical success. Because I don't want my patients on 4 meds. I want them on 0 meds or 1 medication. And they said that combination phaco-MIGS is a decrease in medical therapy on 1 medication from baseline without an increase in IOP. That's okay, right? But that, I think that okay, but that still doesn't capture anything, because meds are so subjective too. I could put my patient on 4 meds even though they don't need to be on 4 meds, and then after some surgery, I can take them off all 3 meds and say, look, I decreased them by 3. So then, and that's the problem with a lot of these studies is when patients are on 4 medications, do they truly need to be on 4? Are they actually using 4? And do all patients need to be washed out? And I don't have a proper, solution to this. But I think this is what we need to start thinking about and be creative about. And this is really where we need the next innovation. Now, and the other thing it said was IOP of less than 21 and reduced by 20%. So, and then the patients could not have had prior surgery. So, what we need is transparency. We really need to just, when we're showing data, we need to show as much as we can and not just hang on one number. I think maybe fewer meds and a lower IOP and not give a percentage. I don't know, but there needs to be something better than just 20% reduction. So, when it comes to MIGS, there's definitely a learning curve, and we're still, I think MIGS is here to stay. And these are some of the pearls on that. But when it comes to what we really need now is innovations in our definition of success. An innovation in our definition of success, as well as transparency, and really more of a heavy focus on decreasing a patient's dependence on drops as opposed to only just pressure. This is a book that just came out a couple years ago on GAT and has about 26 chapters from physicians all over the world. And there's representation from authors in India in this book on how GAT is being performed around the world. It's a great resource for those that are interested in angle surgery and GAT. So, and this is my glaucoma family at home. So thank you for your time.
Thank you very much. Before we go on to your next talk, Dr. Grover, Dr. Tanuj wanted to ask you 2 questions.
So thank you, Dr. Grover. As usual, excellent talks. So regarding GAT, Dr. Grover, I want to ask you that is it recommended to do 360-degree GAT whenever you're doing a GAT, or would it be prudent to do a 180-degree GAT to decrease complications and also spare the trabecular meshwork for a future laser or a drug which may become available?
Yeah, I think that's a really good question. Dr. Tanuj, thank you for asking. The answer is there's not a one-size-fits-all approach to glaucoma, right? So, if a patient has very high pressures on a lot of meds and I need to get the biggest effect I can do, then I would consider a 360 GAT. If they don't need a tremendously low pressure, or they're not on a ton of medications and they're more mild to moderate, then I think you can win with a hemi-GAT. The data out there also suggests that the IOP lowering effect of hemi-GAT is almost as good as GAT, But as you pointed out, usually the hyphema rate is lower. And I think there is rationale from saying, hey, let's be tissue sparing. What if we only do a hemigat? And, who knows, in 5 years and 10 years, if we have some therapy that's directed towards the trabecular meshwork, that might be better. Then at least we preserve some tissue. So I think a hemigat is a very reasonable option. But it really depends on the patient and how much pressure lowering you're on. If the patient's on blood thinners and all those other things. So, but I think hemigat is a very, very reasonable option.
And the second question for you, Dr. Grover, like when you're doing a GAT, you are leaving the two leaflets when you cut through the TM. So those leaflets can fuse and your surgery can fail. So if hemi-GAT is the go-to procedure, so how would that compare to surgeries which cleave the entire TM, like the KDB or the bang, where you don't have leaflets left? Because in the micro hook and GAT, you incise and the both leaflets are left, residual leaflets. But when you excise the entire with the instrument like KDB or a bang, then the leaflets are not left. So any views on the
Yeah,
wound healing subsequent failure if you leave residual tissue?
we don't see a lot. One, you're pointing to something that is really an unknown territory. We don't understand a lot of angle healing, wound healing in the angle. And when you do a GAT, typically you see an anterior cleavage of the trabecular meshwork, and it falls down, and we don't really see the leaflets close again. And even when you do things like the microhook or KDB or bang, it's not like the videos show or the animations show where you're getting that perfect excision and you get that strip. Anytime you even do that, oftentimes you'll see it just tear open, and you won't actually always excise it unless you actually go and peel it out. So, everybody's trabecular meshwork behaves differently. But with GAT and with hemi-GAT, you typically are seeing an anterior cleavage, and then the trabecular meshwork opens up and falls down, and we typically don't see it reform.
Okay. And in your experience, does a prior SLT decrease the success of
We have
MIGS?
not, yeah, it hasn't been specifically studied, but when we look back at all of our patients, we did not see an outcome difference in patients with prior SLT or not. We did not look at if they had a prior successful SLT or a prior SLT failure. We just looked at whether they had a presence of SLT. But it is pointing to, the obvious question is, if an SLT doesn't work, does that mean that their outflow system is no longer intact? And we just don't know that, because if an SLT fails, does it fail because the trabecular meshwork is the problem, or does it fail because the downstream pathways are the problem? And we don't know that.
Thank you. Thank you very much.
So I
Dr.
think
My
as far as SLT is concerned, I think if the SLT has worked for 2-3 years, that means trabecular meshwork is at fault and distal collector channels are still patent. So I think that's a test, which shows that if SLT has worked for a few years, that means MIGs are also going to work. That means only trabecular meshwork is involved and maybe distal collector channels are patent. So that is what I feel, that if it has not worked at all, that's a different thing. But if it has worked for 2-3 years and then failed, then maybe I think the trabecular meshwork is not so good, but collector channels are good.
Yeah.
So, Dr. Grover, can I ask? Yeah, I agree with you that, the interventional glaucoma is transformative, and earlier on it was just TRAB and we didn't want to intervene early because we didn't want to do TRAB in mild to moderate glaucoma. But now with the advent of MIGS, we can intervene early. But just the question is that if the patient is faking, no cataract at all, then you will go for SLT rather than MIGS, or you will still go in for MIGS in patients who are faking, because with cataract surgery obviously we will go for MIGS.
Yes. No, I think SLT should be the first intervention for anybody that has glaucoma, open angle glaucoma. If I had glaucoma, the first thing I'd want is SLT. So I think SLT should be the first line treatment for glaucoma. It's not just what I think; it's what the light trial showed. Yeah. So I don't think anybody should ever have any surgery on their eye for glaucoma, with most cases of open angle glaucoma without having had a prior SLT, barring things like inflammation and all that stuff. But no, I think SLT is undoubtedly the first intervention. So I have to get to clinic. So let me finish this real quickly because we're a little bit delayed. So let me go to the next talk if you guys will allow me. And this will just be quick again. I was asked to speak on kind of the Paul implant. I don't have any personal experience with the Paul because it's not approved in the US. So I'm just going to give you a brief summary of what it is, but I can't speak from personal experience. And then I'll talk about what I typically do with the implant of my choice, which is a ClearPath 250. So this is the Paul implant. It's a little bit smaller than the Barvelt, but about the same. The 350 Barvelt or the 350 Adi. It's 340 millimeters, 41 millimeters squared, but the lumen size is different. Right, it's a smaller inner diameter, much smaller than like the traditional tubes, from 0.3 down to 0.12. And the outer diameter is much smaller too, from 0.45 compared to 0.63. It's a little more flexible. It's still a silicone implant, but they think it's made of some proprietary combination that's less problematic. This is a nice picture. This is from the Keith Barton's YouTube video showing the inner diameter of the Barvelt, the PreserFlow, and the Paul, which is a nice demonstration of the wall thickness and the inner lumen. They think that the internal diameter of the Paul implant and the length of it does create an inherent resistance to hypotony, although they still are putting in a 6.0 Prolene. These are some just comparisons between the size. It's a little bit more. It's a little bit less long and more deep, the dimensions compared to the Adi or the Barvelt. And they typically do recommend putting in a 6.0 Prolene suture through the tube that will still allow some microscopic flow, and then you can activate the tube later. And this is some of the data you guys can read. This was published in the in Ophthalmology Glaucoma back in 2020 on the initial results. They're having tremendous results, but again, we don't ever see these kind of, we don't ever see a 90% success rate in glaucoma. So, we'll see how this is looking once it becomes more broadly used, and by people that are not, tied to the manufacturing and the people that have designed it. But the results are quite impressive. But this is what I typically do. I do the 250 ClearPath. It's a little bit smaller, and it doesn't involve muscle isolation, so I can do this without having my patients have a block. I do this under topical anesthesia with once I open the conj, subtenon's block. There are a bunch of different ways to tie off the tube. The way I now tie off the tube almost invariably is this way, with a 7.0 Prolene tying it off with a 4.0 nylon ripcord that I tuck in the inferior fornix. So that tube is going to stay closed forever until I pull the ripcord in clinic. And I will fenestrate a lot. So I do what I kind of call a tubulectomy. So I make a lot of fenestrations, 5 to 10, sometimes more. So the tube is leaking, right? So you need to close it like you would a trabeculectomy, and need to be very, very meticulous on how you close the tube. Otherwise, you're going to get a leak. But sometimes my fenestrations work for 6 to 12 months, and I don't have to activate the tube for a long time. So the soonest I'll activate the tube is 2 months, but the tube doesn't activate until I activate it. So the patients come in, they stop their meds, I pull the ripcord, I put them on atropine, put them on restrictions, and I have a much more controlled opening. No more are the days in my clinic where patients are coming in on maximum medical therapy, on acetazolamide, their tube opened and they didn't realize it, and their chamber is flat at 5 weeks. I couldn't stand that unpredictability. So now my tubes do not open until I open them. And here's just a quick video, and this is an instrument that I designed that is kind of my second instrument that always stays in my hand. It's my conjunctival forceps. It can tie, it can cut, it can hold the implant. It basically never leaves my non-dominant hand. And I use it for almost all my surgeries that have that need a conjunctival incision. So that's helping me. That's the cutting surface. That's the atraumatic forceps, and this can tie. I don't use it as a needle holder. You can, but I don't. But it can hold the conjunctiva. It can hold the tube. It can hold everything. And so I can open the conj in an atraumatic way. And then once I put the clear path in, I can hold the implant without any problem. I can tie the suture without it shredding, and then I cut the suture with my instrument. Now you got to be careful; it's a little bit awkward. You got to put your hand flat. But I'm not passing my instrument back to my assistant at all. I just stays in my non-dominant hand. I don't depend on them really for a lot anymore. And they actually get bored now in the operating room. So you can cut it. I use it to rotate the sutures. You can actually use it to cut the tube. So it never leaves my my non-dominant hand. And really just manipulate the tube how you want to. You can use it to insert the tube. And I use it to stabilize the patch graft, again to tie it. And it's not this constant back and forth. It just never leaves my non-dominant hand. And then this is the technique I do. Once I'm done here, I tuck the ripcord in the inferior fornix, and again it stays there until I remove it, and I remove it in clinic when the patient's awake, and then I can manipulate the conjunctiva, hold it, and basically I'm able to then close in a very efficient way without constantly tying, handing back instruments and all that stuff. So these are our outcomes with that technique that I'm doing. These are the number of basically almost a mix of men and women, average age of 67. Most of them had primary open-angle glaucoma. But you can see, we're taking patients with pressures of 25 on 4 meds down to, 13 on 1.8 med. And even patients that had longer follow-up, 47 of them had over 2-year follow-up, 11.6 on 1.6 meds. And, these are the complications or the adverse events, nothing major, but no sudden shallowing, because the tubes were opened in a much more controlled fashion. And this is another thing that I kind of designed with the team at Epsilon that helps stabilize the tube and the plate, because the clear path doesn't come tied down, neither does the Eyeedu. So it's kind of, I like to tie it off on the back table as the technician is prepping the patient. So this is kind of what I do as the staff is preparing the patient. I'm on the back table and I'm just tying it off. And basically that's the 7.0 Proline with the 4.0 nylon ripcord, and then it has 5 grooves in it, and the 5 grooves you can pass a 30 gauge needle to make 5 fenestrations. And these are kind of much more controlled fenestrations that I can at least have 5 and have it ready to go. And the tube is ready while I'm waiting for my staff to get the patient prepped. So all these instruments are available through Epsilon. They have a pretty strong presence in India, and Mateen is the president, and he's the one that helps me design all these things. But these are just my thoughts on recent tubes and how I do this. So thank you for the Eye Foundation for putting this together and having me as a speaker. It's always a pleasure to interact with my friends and colleagues in India. And Dr. Chitra, Dr. Murali, thank you for inviting me. And so hopefully one day I'll be out there in person. But I appreciate this exchange, and I have probably time for maybe one question. I am now a little bit, my staff is getting a hold of me because I'm running a little bit delayed. So
thank you
but
so much.
for your
Thank
time.
you so much. Thank you so much. Just that one question, Murli, can you take it?
Yeah, would you say there is any role for antimetabolites as far as the glaucoma drainage implants are concerned, Dr. Grover? Like mitomycin, there's been a lot of this thing on mitomycin C along with the Ahmed glaucoma valve. So, what is your take on the use of anti-metabolites?
Yeah. So you're breaking up a little bit, but the question is use of anti-metabolites in glaucoma drainage implants. Is that right?
Yeah, that's correct.
Okay. So yeah, there's some studies that have shown with the FP7 valved implant, the Ahmed valve, that that it can be beneficial. But again, it's so hard because patients that are getting Ahmed valves, it's such a mixed group. They're sick eyes. A lot of them are neovascular eyes. They don't tend to do well anyway. I think there's a theory that it reduces the size of the capsule, the thickness of the capsule, and might improve outcomes. But I don't think there's a consensus on it yet. With this technique, I don't do FP7s anymore. And when I do, in the rare situation, I don't use mitomycin C. I don't think it would be harmful to use a little bit of mitomycin C. I would strongly discourage people from using mitomycin C with the non-valved implants, because if any of you have ever had patients with a non-valved implant that the tube activates and there's no capsule, it's miserable there, and you have to take them back to the operating room. So you don't want to put the patient at risk of not having the capsule form with a non-valved implant. The valve theoretically can protect the patient from extreme hypotony, but mitomycin C can be very humbling. And you can get burned pretty badly with it. So I think if it's a sick eye, neovascular glaucoma, pretty hot, inflamed, I think it's not unreasonable to use mitomycin C, but I don't use it on a regular basis.
Has the company reduced the lumen size of the FP7 Ahmed valve also? The lumen.
Yeah, the lumen size for the FP. Yeah, the lumen size for the FP7, the ClearPath, the Barbell, and the Eyeedu are all pretty much the same. Yeah. Excellent. All right. Well, thank you guys so much. Enjoy the rest of your evening. All right.
Thank you.
You're welcome. Good to see everybody. Take care.
Thank you. So we go on to our next speaker, Dr. Subhasini, after a wonderful couple of talks by Dr. Grover. And we all know, is a professor of glaucoma and cataract and refractive services at JIPMER Pondicherry. And she's going to be telling us what's new and important in OCT for glaucoma progression. On to you, Dr. Subhasini. Sorry for breaking the sequence, but she had to go somewhere else too.
Thank you, ma'am. It's actually indeed a pleasure and honor to be on this platform amidst stalwarts in glaucoma. So the topic given to me is what's new and important in OCT for glaucoma progression. We all know that assessing glaucoma progression is a very crucial component in the evaluation of the glaucoma patient, and quantitative assessment with OCT will help us to detect minute structural changes over time. And there are a lot of longitudinal studies on OCT progression, which has provided enough evidence to show that OCT is a very useful tool in assessing progression. But glaucoma progression using OCT has a lot of challenges. And this is because of a number of factors. One reason is because of the slow progressive nature of the disease itself, and then the measurement variability between the different OCT devices. And then there's no reference standard to assess this age-related change in the RNFL thickness, and then the test-retest variability, and several other aspects. So the most commonly used machines, the Cirrus and the Spectralis machines, if you see the age-related loss, some cross-sectional studies have shown the age-related loss in the RNFL thickness to be less than 1 micron a year. And the test-retest variability among the various devices, it has shown with Cirrus OCT, it's around 5 microns. So what some studies have told that the average RNFL thickness, if it decreases by more than 4 microns, and this you can consider as a statistically significant change for assessing progression. My slides are not moving.
Go to the lower.
My slides have stopped moving. I don't.
Oh, your talk is on preventing progression.
No, assessing progression. Can I just reshare? Sorry.
Yeah.
Yes, ma'am.
Yeah. So it's a good idea to follow the rule of 5. So repeated testing in OCT of when there's a loss of more than 5 microns or more, that is suggestive of glaucoma progression. But this is, we need to take it with a pinch of salt. There can be high false positive rate. So the GPA is the guided progression analysis software. It's a statistical package with the OCT, and it's one of the robust approaches for the detection of progressive glaucomatous damage. And just like the GPA HFA, there is an event analysis and a trend analysis. In the event analysis, the current OCT scan is compared with 2 baselines. And in the trend analysis, it gives the linear regression with serial scanning. It shows a linear regression over time, and it comes in the form of a slope. And now if you see the event analysis here, there's an example. You can see the current fields, which is current OCT, which is checked with 2 baselines. And you can see it's flagged as yellow at the first examination when there is more than 5 micron difference. And if the same changes are repeated, then it is flagged as red. And it's a good idea to change the baseline test if any significant loss is noted recently. With the trend analysis, you can see the RNFL thickness profile and the rate of change with serial exams. And here you can see in this picture, the average RNFL thickness plot, the superior RNFL thickness plot, the average cup disc ratio, the inferior RNFL thickness. So all this, it gives the slope with over time. And here you can see the current OCT being is compared with the 2 baselines, and the variability is given in the graph as a blue line. And if the changes are seen in a single test, there appears a yellow tick. And if the changes are noted in 2 previous tests, you see a red tick. And that indicates likely progression. And if you see at the green box, so you can see the slope, and there is a gray area. So, and if you enlarge this picture, so you can see this gray zone that indicates the 95% confidence interval for the values. And if these dots appear red, that is indicative of possible progression. And if there's a red dot, that indicates likely progression. So just like the GPA RNFL, there's the GPA GCC ganglion cell complex, or the GCIPL, where the current GCIPL scan is checked with the 2 baseline scans. And the first time when the significant change occur, it is flagged as yellow. And with repeated examination, it is flagged as red. And this is an example of GCIPL GPA changes occurring much earlier in exam 4, it's yellow, and exam 5, it's you can see the red pixels. But in the RNFL GPA, the changes have not yet occurred. And even in the fields GPA, the progression occurs in examination 7. So this is another example which shows the GCIPL thickness change, which is occurring much earlier than the RNFL thickness change, which occurs much later. But this is not always the case. As in the lower example, you can see that the GCIPL thickness changes are occurring much later as compared to the RNFL changes, and the field changes are also occurring earlier. So we need to, so everything is complementary. So you just can't simply do the GCIPL. So it's you need to do the RNFL, the GCIPL, and also compare it with the GPA fields. So if we see the sensitive parameters for PRNFL, it's the average thickness and the inferior sector thickness, which are very sensitive in assessing progression. For the optic nerve head, it's the BMO, MRV, MRW, but it's not actually as useful because the BMO recedes with age. And the macula is very macular GPA is very sensitive in detecting progression, especially in advanced glaucoma when the RNFL has reached its floor effect. What's new? Like we have this Whitefield swept source OCT. So this has the advantage. You have a combined report of the optic disc as well as the macula. So and subtle changes can be detected, as you can see the white arrows indicating the RNFL change. And there is also the concept of region of interest, ROI, which actually means that the area adjacent to the disc hemorrhage, where the disc hemorrhage has occurred in the peripapillary area. And the disease can be monitored by looking at the width of this ROI. Because already the RNFL in advanced glaucoma would have reached the floor effect. So ROI is a useful way. And this is another way of assessing the glaucoma progression, where you look at the macular vulnerability zone, which is below this inferior GC IPL. So, and you monitor with the width of this macular vulnerability zone. And Octa, so this is futuristic. So definitely this is going to be useful in assessing glaucoma progression. The vessel density in the peripapillary and macular area, the reduction in this density over time
Doctor,
will
1 minute
be
more.
useful in assessing progression. And adaptive optics is another promising way. So it's a high resolution OCT. So because of the reduction in artifacts, you can actually see the openings, the laminar pores in the lamina cribrosa along with the beams. And in fact, you can count the nerve fibers. So, and this is a very useful technique even in early glaucomas to assess progression. To summarize, SDOCT definitely is useful in discerning the course of glaucoma progression and prediction of disease prognosis and evaluation of treatment response. Thank you.
Thank you. That was a wonderful talk, Subhashini. Very thorough. I'll take a question. Dr. Gauri, can you tell me, like, supposing the patient is showing some progression in OCT, would you think of that, but it is not showing progression in the fields? Would you think of taking up a surgery or something augmented therapy based on that alone?
Dr. Chitra, firstly, we never take anything in isolation. We need to take the whole picture. So I should be able to see that the clinical picture is correlating with the OCT. That means that the eye pressures are slightly out of range, or they have not been at the target that I have set. And there are some clinical changes as well. And even then, what is that change which I see on the OCT? If it is just a few pixel more or a few points on that change map, the pixel analysis, I will not take that to, suddenly jump towards surgery. Okay. So I'm going to check that again, maybe 1 month later or 3 months later, more realistically, and reconfirm that change and then only decide whether I need to intervene. I mean, surgical decision is not taken based on the OCT alone most of the time. We go more on the visual field rather than the OCT. And mind you, there is no point in comparing one machine to another. When I'm talking about change in OCT, it is on the same machine with the progression algorithm software. And with that, I'm seeing a meaningful trend towards the downward level. Like I have seen a change and I'm reconfirming it. And the rest of my clinical data fits in. Then I will consider a change in my management algorithm, not based on just a 5 micron change or a step down in the OCT.
Murli, any question before we go on to our next speaker?
I just want to have one
Yes,
comment.
yes.
I think Dr. Subhashini really presented very well all the different aspects of progression. So one practical point is that when you follow up these patients over time, many of them are starting to develop cataracts. And what you see is that the visual field, the signal strength goes down. And that can give a false progression. So you must, whenever you interpret progression, you must have a look at what is the signal strength coming on top. So sometimes the cataract progresses, signal strength goes down, and you get a false progression. So then you have to do the cataract surgery and re-establish the baseline. Then you see suddenly all the parameters are back to normal again. So that is one important thing. Any posterior capsule opacification or cataract should be taken into this false progression, which can occur due to the signal strength being lowered. Thank you.
Thank you.
And another thing I want to stress is that OCT should always be seen in conjunction with the optic nerve changes. Sometimes you see RNFL defect clinically, and there is a disc hemorrhage, which you can see. And if there is progression of RNFL defect, you will see that, after disappearance of disc hemorrhage, there will be progression of the RNFL defect. So that's a true progression. And in that case, you should modify your treatment even if there's no field changes. So clinical, I think optic head evaluation is very, very important. And if there's a disc hemorrhage and then progression of OCT changes on 2 consecutive visits, then that is an indication that the glaucoma is progressing. Provided your media is clear and, as Tanu said, that there's no false progression. So I think that is very important.
So there are
Very
two
relevant.
parameters. One was GCL plus and other is GCL plus plus. This GCL plus plus means the inner plexiform layer is also included. I mean, which is more sensitive. She actually showed 2 ganglion cell. Even we have seen in our OCT also. One is GCL depicted as GCL plus, the other is depicted as GCL plus plus. So the plus plus has a higher thickness. So does it mean the inner plexiform is also included? What does that GCL plus plus mean?
So, what are your thoughts on it, Murli?
No, I think the GCL plus plus, the machines cannot measure the. I don't have a confirmation from the company on this, but the OCT cannot measure the ganglion cell alone. So it actually takes into account both the ganglion cell, inner nuclear, and inner plexiform. Or some machines measure the ganglion cell and the inner nuclear layer. Inner plexiform layer. So I guess if the inner nuclear layer is also included, that is plus plus. That's what I felt. Any thoughts, Dr. Subhashini? Though I don't have, this was just my thought on it. I've seen it in many machines, GCL, 2 GCLs, one is GCL plus and plus plus.
So, I think there are very thoughts on that. So, we go on. You have anything else to ask? Shall we go on to the next speaker, Dr. Murli?
Yeah, I think we'll go on, madam.
Yeah. Our next speaker is Dr. Padmini, is a consultant glaucoma services at the Eye Foundation Group of Hospitals based at Coimbatore. And she's going to tell us something equally important and interesting. What's new and important in ASOCT in glaucoma? On to you, Dr. Padmini. You need to unmute yourself.
Good evening. Thank you, ma'am. Good evening, everyone. I'll be discussing about the advancements in ASOCT in glaucoma with the focus on the Swepsos powered Antirion, which is a multimodal imaging platform optimized for anterior segment imaging. And this one is also used for corneal examination for anterior segment biometry, IOL calculation, and anterior segment imaging via 4 different apps shown here: the Cornea app, the Cataract app, the Metrics app, and the Imaging app. The Imaging app is incorporated in all the other apps, and it has an eye tracking system, and it has a very short acquisition time. The SSOCT technology at 1300 nanometer delivers high resolution images of the anterior segment along with a large image depth up to the posterior surface of the lens is seen, and the lateral scans allow for cross-sectional imaging at a very fast acquisition speed, and it produces several A scans of the eye with an axial resolution of less than 10 micrometer and a scan depth of 14 mm. Here we see the different apps which are there and the different parameters which are measured in the Antirion OCT. And the table here shows the range of measurements which are
measured by the anterior OCT. Coming to the important one, the metrics app, which gives us the parameters on the anterior chamber angle. Apart from the conventional parameters like ACA, SSA, AOD, and TISA, it also gives lens thickness and lens vault. They also give the corneal component of CCT and spur to spur distance. So what's its role in glaucoma? The imaging and metrics app can be used to study the anterior chamber angle, the AC parameters. The imaging app can be used to study the bleb morphology in a more detailed way. In post MIGS, we can use to visualize the groove or shelf, the tube position in post GDD cases, also to assess the patency of YAG PI. So here the imaging app shows the depth of acquisition and it's an excellent imaging tool. It captures from anterior surface of the cornea to the posterior capsule of the lens using different scan patterns shown here, the line scan, the arc scan, the volume scan, and the radial scan. The metrics app measures the indices and parameters of the AC angle, gives a quantitative assessment of the AC volume. Also, it gives a 360 graph of the angle parameters. As shown in this video, it takes 6 radial scans, and finally, we attain the cross-sectional image. These are all the parameters of anterior chamber angle which are measured using the anterior OCT. And here we've seen marking of the TISA, the AOD, and the ACA at different ACA at 500, ACA at 750, the SSA at the scleral spur angle at 500 and 750. This image on the right shows that it also gives like where exactly the scan has been taken and the corresponding cross-sectional images. And we know that this has been taken horizontally, and the nasal and temporal sides are marked, and we know exactly where the image has been taken. And we get a 360-degree view. And here, the important thing is to measure the anterior chamber angle. The scleral spur point and the anterior chamber angle recess point has to be marked. The scleral spur is actually automatically marked using a deep learning algorithm. It can also be marked manually. And the ACA recess point has to be marked manually. And point to be noted is to measure the angle parameters in these 9 quadrants. In each of this, we have to mark the scleral spur and the recess point manually. So here it shows how to mark the anterior chamber recess point. The scleral spur point is already marked by the machine, and the ACA is marked as the hypodense, the last hypodensity, last pixel of the hypodensity from the superior border, between the superior border of the iris and the cornea. So once we mark this ACA recess, we get the parameters which include the ACA, like the ACA at 500, ACA at 750, and the AOD. So these are the different angle measurements which are done using the anterior segment, the anterion. And a study done by Pradhan et al. In Nepal eyes gave us a reference criteria. This was a reference criteria, as I've mentioned here. This was used as a screening tool, and they kept this as a reference criteria to refer the patient as angle closure suspects for further examination. And another study, actually, they were comparing the anterior chamber imaging using Swepsos OCT in Cassia and Anterion. And they also gave certain values of how it was in the normal and how it was in the PACD eyes. This can also be kept as a reference point for us. After studying the post-PI changes, a study by Medri et al. Showed that all the temporal ACA parameters showed a significant widening after PI. And this is using the imaging app. We have seen all these 3 images here show a patent PI, beautifully shown. But this image shows that the PI is not patent. It can be used as an additional tool to assess the patency of the PI. A word on iridotrabecular contact index. A study by Gupta et al. on quantification of the iridotrabecular contact in primary angle closure disease. They measured the ITC index using an inbuilt semi-automated software in Cassia. It's also a Swepsos OCT. And they measured the ITC index in post-PI case, pre and post-PI in all the subsets of PACD. The ITC index was measured using the scleral spur and the ITC endpoint, which was marked manually. And they found that the ITC index in angle closure eyes correlates significantly with IOP and visual field index. And it could be used as a biomarker for management of glaucoma. So this image shows that the image A shows pre-PI image, which shows that there is 100% iridotrabecular contact here, and also the graph is above the mark of 0.75. And post-PI, even though there is some amount of iridotrabecular contact here, it shows that the ITC index has come down, and there is some amount of residing of iris, and the angles have opened up. So this could be used as a biomarker in management. A word on lens fault, which is a surrogate measurement to know how much of the lens is anterior to the plane of the AC angle. Increased lens fault may worsen angle crowding in already predisposed eyes. And lens fault is an anterior segment risk factor for angle closure. In a study where they certain studies where they compared normal controls to PACS or the angle closure eyes, they found always that the lens fault was higher in the angle closure eyes. And in another observation, they saw that if a patient had acute angle closure attack and they compared it with the fellow eye, the fellow eye also had a higher lens fault. So in this study, where they were studying the impact of lens fault on visual acuity and refractive error, they concluded finally saying that the lens extraction could be considered in case there is a large lens fault in absence of visually significant cataract. This is a topic of discussion. We are yet not sure about how it really add to the management of angle closure glaucomas. So coming to the imaging app, it could be used to study the bleb morphology. The old bleb and the new bleb are shown beautifully here, the cystic spaces. In this image, it shows that there is a bleb leak over here, which helps us in further deciding on the management. If there is a bleb leak and the scleral bed is intact, we can go for a bleb sparing revision procedures. In post-MIGS, in this image, we can see a groove or a shelf. In the other image, we can see there is a little bit of fibrous tissue which is forming, which can cause late spikes of IOP, which indicates that the MIGS is
Doctor,
failing.
1 minute more.
And this image shows that the positioning of the GDD, we can measure the GDD cornea angle, we can measure the distance, we can see if there is a touch, cornea tube touch to the corneal endothelium. Here, it's also used to measure the ICL vault. We can know if the ICL vault is ideal, undersized, or it is oversized. This is one image capturing the cyclodialysis cleft. And another image, we could capture the iris cyst also. And this image is showing vitreous in anterior chamber. And this image shows IC syndrome and multiple PAS. And this was one of the images where there was a foreign body between the iris and the cornea. There could be only a bump was seen on the iris, and when imaged through anterior, we could actually find a foreign body. So to summarize, the Swepsos OCT-based anterior, it's an excellent tool for imaging of anterior segment, also in accurate measurement of angle parameters, which are comparable to gonioscopy. Though it has not replaced gonioscopy, it can be considered for screening in peripheral centers because it's non-contact and it has a quick acquisition speed. And it can also aid in glaucoma management. We're looking for future developments. The company has told that it could come up with the cell counting also in AC. And one of the topic of discussion which I wanted to put across was, can early lens extraction be considered in case there was an increased lens vault, or if there's a persistent angle closure or progression of the disease in spite of a patent iridotomy. Thank you.
Wonderful presentation, Padmini. Lot of food for thought. I would want the expert panel to pass their comments in this connection to this talk.
Dr. Padmini, very nice talk. I am another proponent of the anterion. I use that extensively in my cases, especially the secondary angle closures. Whenever you don't know what is the cause, so this can actually make a difference even in the management. So it's a very underutilized tool. Compared to the other ASOCTs, the resolution is very, very good. And you showed some very nice examples, malignant glaucoma, the patency of the PI, and these kind of things, and foreign bodies. I've had a case where there was a bee sting and the sting was missed. It was picked up on the ASOCT that there was a foreign body in the area of PAS between the iris and the cornea. So the ASOCT is definitely something that we should use more. You told a lot about the use in primary angle closure. Definitely lens vault and other things you need to take into consideration, but I would not jump into saying that just based on that do surgery. I mean, again, you take the whole patient into consideration. If you have a patient with primary angle closure where the lens vault is high and your IOP is uncontrolled and you're wanting to operate, definitely I will do a phaco or I will remove the lens. Whether I do an additional trap or not is another decision altogether. So in an angle closure, if the lens is thick and the vault is high, I would definitely lean towards removing that cataract rather than maintaining it. Because with that big lens, if I do just a trap or glaucoma drainage device, the chances of aqueous misdirection are quite high. So that is to answer your question that you asked at the end of your talk. Very nice talk. Thank you.
Thank you, ma'am.
Dr. Sunita, Dr. Pandav, anything to add before we go on to our next speaker?
I think I agree with Gauri. In angle closure glaucoma, I think lens is the causative factor. And if the lens vault, I think there's a cutoff. If the lens vault is more than 900 on 1000, the AC is really very, very shallow. And it is always advisable to remove that lens because it will cause further shallowing and narrowing of the anterior chamber. So cutoff of, I think, the lens vault is, we always get the lens vault done when we see that the lens appears to be thick and the central AC shallowing is there. And I think the threshold for cataract surgery is pretty low in patients with angle closure glaucoma, although we are still not doing very clear lens extractions in angle closure glaucomas.
I think very well covered topic. I think and the use for anterior segment OCT is actually increasing in the anterior segment and especially in angle closure, as you said. Very well done. I think Dr. Padmini did a good job. And I do agree with what Dr. Sunita said. I mean, our threshold for doing cataract surgery is lowered now. I think once there is a cataract and there's angle closure, I think we have a tendency to go in early. But again, for clear lens extraction, and unless there is specific indications, so we kind of avoid that. And also, along with the lens vault, you also look at the overall anatomy of the eye, the axial length, and the lens thickness as such.
Thank you. Muli, I'll go on to the next speaker, unless you have something to add. There are still some gray areas.
One question for Dr. Pandav, if that's okay. What I wanted to ask was in pediatric, post-pediatric cataracts, especially when the kids are young, let us say 4 or 5 years, and you feel the corneal diameter is not great. So can you use the do you have any experience of using the ASOCT, because they may not permit gonio? The kids may not permit gonio. So in serial follow-up of these patients with pediatric cataract, do you have any experience, sir?
I think it can be done in children also. I don't do pediatric cataract such, but I think we do a lot of ASOCT for pediatric glaucoma, where again we find it very useful in defining the morphology, what is happening behind the relatively not so clear cornea. So we do a lot of UBMs, but I think we are now doing more and more ASOCTs even for smaller children. And also, to look what's happening to the lens in the posterior part of the lens. Is there any anatomical problem there, any posterior polar, or sometimes they have that, the persistent, artery or something. So I think in children, it would be useful, and certainly it can be done in kids as well, because the image acquisition time is very fast. So you just, so it can be done. Yeah.
Thank you very much. We go on to our next speaker, Dr. Vaishnavi, a very dear friend of mine, and who's into her private practice, doing well at Clearsight Eye Clinic, Coimbatore. And she's going to be talking on what's new and important in virtual reality perimeters. On to you, Dr. Vaishnavi.
Thank you, ma'am. At the outset, I would like to thank Dr. Chitra madam and Dr. Muralidhar sir for giving me this opportunity. So I'm here to talk about what's new and important in virtual reality perimeters. Sorry, ma'am, slide is not moving.
Keyboard arrow mark use பண்ணனும்.
Keyboard liya.
Yes.
அதான் யூஸ் பண்ணேன். இப்போ வந்ததே.
Stop share பண்ணிட்டு மறுபடியும் again connect பண்ணுங்க.
Okay.
Yeah. In the interim, Murli, are you there, Murli? What is your take on the deep learning algorithms of Antirion for marking the scleral spur? How reliable? I mean, how would you?
The Antirion actually, madam, has a very good deep learning algorithm that automatically detects the scleral spur. You still have to mark the anterior chamber angle. The problem with the deep learning algorithm is it is reasonably accurate in the temporal quadrant of each eye. It's not that great in the other quadrants. Even when the blinded experts were asked to mark the scleral spur, they could confidently mark the scleral spur in the temporal quadrant in only 70% of patients. But the Antirion succeeds in marking it all the time. But we are not very sure whether it is accurately marking or not. So it gives you an option to edit the scleral spur. And of course, ACA has to be, anterior chamber recess has to be, angle has to be manually marked. I mean, that anterior chamber recess point has to be manually marked. So once you edit the scleral spur, it gives you a warning the scleral spur has been edited. So having said that, I mean, it's a useful addition in that it automates, but doesn't really reduce the time, because as Padmini showed in the video, you have to mark the anterior chamber angle and check the position of scleral spur in all the quadrants. So yes, it is a useful addition, and because it's a deep learning, machine learning, so we hope that over a period of time, the company actually improvises it to such an extent that the accuracy increases. But as of now, the accuracy cannot be considered as more than 70%, and so it has not replaced gonioscopy.
Yes, Vaishnavi, on to you.
Yes, ma'am. So as we all know that Humphrey requires maintenance of constant fixation, and it is very stressful for debilitated, claustrophobic, ill or elderly patients to keep their heads still in the perimeter bound. And it is not possible for any bedridden patients and patients with musculoskeletal problems. So these are the challenges faced with Humphrey. They are bulky devices, high cost, and it's inconvenient for patients with postural difficulties. So now perimeter has been developed, which is portable, simple, and very accurate. This is an outline of AVA LSR. It has got a head-mounted device. It has got a built-in eye tracking system, and it has got an ergonomic strap to maximize the patient comfort, and has also got an adjustable interpupillary distance. And this is a test controller, which has got a setup and a monitor test. It works by wireless control. It has got a cloud data backup, and it has software which is updated over the air. And this is a patient response button, which records a patient's response, and it is very easy to grip. And all these can be packed in a safe backpack, and it is very easy for transport and storage. It is portable, it is head-mounted setup, and it's very flexible. The patient need not fix any position, and it is very compact. And it tests up with a few clicks. It uses onboard gaze monitor, and this monitor and control test over a wireless connection and virtually sends report through the email, or it can print wirelessly. And main advantages is that it is lightweight and portable, and it does not require eye patching, because each eye is stimulated by an individual screen, which is isolated from the fellow eye. And the screen is located around 60.5 millimeters in front of the eye to avoid overlap of screen. And there's no need to maintain any particular head posture and it is very easy to adjust the headpiece to optimize comfort for the patient. It's kind of very lightweight, around 300 grams, and it has got a light emitter diode display. And this display is divided into two halves, one for each eye. And this display subtends an angle of field of view about 100 degrees. And the tracking system consists of gyroscope and accelerometer. And it has got two arrays of 6 infrared-based sensors. And it has got an excellent eye tracking system. The accuracy is as great as less than 1 degree. And it checks the gaze position to automatically adjust the location of the stimulus. So if the patient has a normal fixation, the test continues. But if the patient has an eccentric fixation, and if that fixation falls within the central 15 degree, the machine automatically readjusts the stimulus based on the new fixation point. But if the fixation is outside the central 15 degree, the device stops and then it presents a signal requesting the patient to return to the central fixation target. And this is a study made by AO. So after exclusion of all the data with a threshold value of less than 19 decibels and on reanalysis, there was no proportional bias detected in any of the patients for mean sensitivity and PSD between the two machines. So this value derived in this study lie within the prescribed limits and suggestive that all these head-mounted devices have a potential to serve as a diagnostic tool for visual field imaging. And yet this is another head-mounted device which is called the C3FA analyzer. This has got a rechargeable battery and does not need any external power supply. So as usual, the patient can be either standing, sitting or moving or lying down. It does not require any internet connection and can connect wirelessly to operator's smartphone. And this is a home-based visual field analyzer. So the advantage of this system is that it uses a webcam as a photometer and validates the reliability of the results when the test is completed. So this system also allows the patient to send the result to his or her doctor by email and also allows the doctor to combine all the tests and combine it as a single test to achieve the higher accuracy. So this software uses a web camera as a virtual photometer in order to detect the luminosity and allows a self-testing using a computer monitor or virtual reality glasses using an Android system. And much newer technique is called the visual grasp technique. So here, the eye tracker detects the changes in the gaze as the direction of the stimulus. It mainly takes advantage of the natural tendency to look at the new moving and transient visual stimulus. So this is based on the theory that the M cells inside, it inputs to a reflex which is unsuppressed, which drives the eye to acquire a novel target to the fovea. It does not require any manual input nor cortical processing and any decision making from the patient. So the patient is asked to look at the direction of the fixation target and then if the stimulus is visible in the direction of the stimulus. Then the positive detection is determined by the analysis of the tracker data. If the patient's change is consistent with the position of the stimulus with respect to the current fixation point, the positive detection is deduced. When the stimulus is detected, the fixation point moves to the position of the detected stimulus. But if the stimulus is not detected, the fixation point remains in the same spot and another stimulus is presented. So this is an article using the visual grasp technique. So this study validates both the concept of head-mounted using the virtual reality type perimeter and the visual grasp using both the mode. And then they found out that visual grasp technique uses very much high sensitivity and it is almost as comparable to the normal Humphrey field. And other newer modalities include the pupil perimetry, which measures the amplitude or latency of the pupillary response using the infrared pupillometer. And one of the main newer modality is the N-Google. So this N-Google uses a brain-computer interface using EEG. So what happens is this uses a brain-computer interface using the multifocal steady-state VEP. And it has got a wireless, easy-to-wear neuromonitoring unit, which has got a dual-code processor with Wi-Fi and Bluetooth connection. And it captures all the electrophysiological signals from 6 EEG and 4 EOG electrodes. So this N-Google was able to discriminate glaucomatous eyes from the healthy eyes, and it shows adequate test and retest repeatability. And these SSV VEP signals were lower in glaucomatous eyes compared to the healthy eyes. And they say that in a recent study, this N-Google detects glaucoma even before the appearance of visual field on standard perimetry. And it is also very less susceptible to artifact. So this even in the 10-2 as compared with the Humphrey fields, this shows a positive correlation between the mean deviation, mean sensitivity, PSD between the Humphrey and the head-mounted device. And area under the curve for both the devices show good quality, and it was able to discriminate between the controls and the glaucoma patients. Area under the curve, mean deviation, mean sensitivity was almost similar between the two devices. And so this can be stated that even for diagnostic purposes, both the devices almost are comparable and similar. So even in my clinic, I had compared a few patients with Humphrey field with the LSR in both 30-2 and 10-2, and the results were almost very much similar. So coming to the main advantages, these HMD devices which have come recently, they are portable. And the main advantages is that it can be tested in any position, and it decreases the test-induced fatigability. And mostly they are preferred in patients with cervical or spine diseases, weight issues, if the patients are hospitalized, or any bedridden patient. And even the eye tracker is more accurate than Humphrey. And the patients can wear their own glasses, and there's no need for trial frame. So to conclude, so despite listing the decibel values between 0 to 8 as less than 8, no other significant difference was found between the mean sensitivity and the mean deviation between the two devices. So this study by Narang et al. Demonstrated that the threshold estimates and the global indices derived from the Humphrey correlated well with the head-mounted devices. So this discriminates healthy from the glaucoma patients and correlate well with the HVF. So its main interpretation in office and teleophthalmology can be beneficial to large group of patients. So however, studies with large group of patients and studies are essential, and they are underway. Thank you.
Thank you, Vaishnavi. As usual, you are very crisp and you could try your best to convince us to go for this.
Had already recommended to many centers. So right. It actually, it's some few comparison, and the patients whom I got this LSR head mounted, the main disadvantages who what they tell is, ma'am, it was little bulky. That's what I get the input from the many patients. And other advantages what I had heard from other patients using for the first time is that, as I demonstrated in my slides, they can just sit on the sofa, they can be relaxed, and they don't have to keep their faces thrust upon this Humphrey. And people feel that Humphrey was little claustrophobic, all inside one room, which is dark. And these were the advantages which I had faced. And any other inputs, ma'am? Gauri, madam?
Very nice talk, Dr. Vaishnavi. I see the virtual reality or the head-mounted devices have a future, definitely. But we are still not there where we can use it in substitution for the Humphrey perimeter or a good threshold perimeter like the octopus or whatever. That's because we don't have too much data. I'm sure as we go along, we will get it, and that is the way to go. I mean, it would be my dream to have a patient do the field at home and send me the field every month or every 2 months if it is a reliable thing, because I can track the changes and even dream that an imaging will also be happening through the same thing, through the pupil, and that also comes to me and I teleophthalmologically see. These are all, we're free to imagine the future. Definitely it is the way things will progress, and it has a role even today, like in neuroophthalmic cases, like where you want to know the field, what kind of a defect is there. In children, where you cannot do a Humphrey or a threshold perimetry, you want to document it somehow. This may be more friendlier for children. For people who are very old and cannot sit with their neck in the machine, doing this kind of a field is better than having no field at all. Okay, so I am sure we will reach a place where these will become the norm rather than the exception. But today it is an emerging technology, and we still rely on the threshold perimeters that we use, the Humphrey, the octopus, for our routine decision making for patients with glaucoma.
Yes, thanks, Gauri. Truly well summarized. But paucity of time, we have to move on without further discussion. And I invite Dr. Arvind Kumar Maurya, a very dynamic ophthalmologist, a professor of AMS at Hyderabad, and who is extremely innovative and is confident about the products he innovates and talks about. So let's hear what he has to say about the A to B implants, the indications and techniques. On to you, Dr. Arvind.
Thank you so very much, ma'am. Is it full screen? It's visible?
No.
No.
sir.
No, sir.
Is it my screen is visible or not?
No.
But it is showing. Okay, I will stop share and
Yeah,
again
share it
reshare.
again.
Yes, sir.
Yeah, again you have to reshare. That's what happened to me also.
Hmm. Stop sharing and then share. Is it visible now?
Yes, sir.
Yes, sir.
Yeah, thank you. So good evening, esteemed chairpersons, expert panelists, moderators, and thank you, the Eye Foundation, for giving me the opportunity, and especially Dr. Chitra ma'am. So my talk is on A to B shunt, glaucoma drainage device in the refractory glaucomas, indications and the technique. And I have no financial interest. So these are the A to B from anterior chamber to the back of the eye space, that is a retrobulbar space shunts, and made of silicon. So if you see, there are three zones. So one is in the anterior chamber with diameter of 0.3 millimeter, and then the reinforcement zone at the pars plana. The size is 6 millimeter into 1.6 millimeter with three serrated edges for fixation, and then goes into the retrobulbar space with 1.02 diameter with fenestration for the aqueous drainage. So there was this study by O.R. Battle et al. And sponsor WE, who is the innovator of this A to B shunt. So they found out in animal model that it forms a lymphatic like microcirculation system, and it doesn't blocks. And then the sponsor also did a human clinical trial in 35 of the eyes, and the results are very promising. The IOP from 35, and these were the uncontrolled refractory glaucoma cases, failed trap, and fibrosed encapsulated blab. So they implanted this A to B shunt, and the average IOP fell down from 35 to 17 millimeter of Hg at 6 months of the time. And it is developed at the Bilbao, Spain, AJL. And why? Because this is a very good option in the refractory glaucoma, because it drains into the hydrophilic periosteum of the orbit. So they form these micro canaliculi and adjacent adipose tissue. So they have this microcanaliculi, and that's why it doesn't block. So we have our innovation, that is again a A to B from the anterior chamber to the retrobulbar space. CDSU and DGHS approved OmniFlow. So this is a video. Greetings everyone. I am presenting my video on a new innovation, that is OmniFlow, a novel, small and effective drainage device for complicated open-angle glaucoma. OmniFlow is a unique sutureless, sure shot shunt and the best glaucoma drainage device to drain aqueous humor from anterior chamber to retrobulbar space. A micro-wall tube pressure regulator is fitted inside a soft flexible silicone tube which controls the outflow of the aqueous humor, which will prevent hypotonic and maintain IOP between 10 and 24/7 with no to minimum need of anti-glaucoma medications. This is how OmniFlow tube looks. Minimum IOP back pressure is maintained by Bernoulli's principle, which essentially means that in a narrowing tunnel, the primary pressure P1 is proportionately resisted by secondary pressure P2. Minimum IOP of 10 mm of Hg is also maintained by another principle, that is anti or reverse capillary action, which means that if capillary is hydrophilic, it will attract and suck the water, but when the capillary is hydrophobic, it will repel the water back. Hydrophobic capillary wall tube made of Teflon will resist the aqueous humor passage, maintaining a minimum back pressure of 10 mm of mercury. Retrobulbar space behind the equator is almost free from myofibroblast. Therefore, it is virtually free from fibrosis even without mitomycin C. Retrobulbar space can easily drain up to 500 microliters per minute without any engorgement, proptosis or chemosis. Aqueous humor production and outflow discharge rate is only 3 microliter per minute. OmniFlow supplied tube length is 50 mm and needed length is 30 to 40 mm.
What's happened?
Yes, ma'am.
Stopped, no, suddenly?
Ma'am, sir, internet is very slow, I think.
Oh.
Dr. Arvind, sir.
Our internet is bad? Velmurugan,
Ma'am,
is our
service.
internet bad?
Oh, no, ma'am, no, ma'am. Our strength is good, ma'am.
But we are not able to hear anybody else.
No, we can hear you. I
Hmm.
think his presentation stopped.
I think he lost the connection.
Yeah,
Oh,
we can hear you, I think.
okay.
We
can
can
go
go
to-
ahead with the other presentation.
Go to the next part.
Yeah, next. Yeah.
It's quite late, and look forward to, really thanks a lot, Dr. George Putran, for being a part of our webinar. And it's so unfortunate that such a wonderful person as you have inadvertently put you as our last speaker. And it's truly a delight to have you. He's the Chief of Glaucoma Services of the Arvind Eye Care Systems based at Madurai. And he's going to talk to us on another quintessential topic, minimizing corneal complications in glaucoma drainage devices. So on to you, Dr. George Putran.
Thank you, Chitra ma'am and Eye Foundation for this opportunity. I am having problems with the internet, so I've asked Velmurugan to just share my presentation from his end so that...
Yes, Velmurugan, can you connect?
Yes, ma'am. Yes, ma'am. I will.
Very unfortunate. Dr. Arvind was here right from the beginning, and somehow his network went.
Yeah.
Yes.
Thank you, Mr. Velmurugan. I'll just say next for the, when you have to just change to the next slide. So next slide.
Velmurugan, next slide.
So the potential mechanisms for corneal decompensation in glaucoma drainage devices are mechanical damage from tube endothelial contact. This is probably the most common and preventable mechanism. There are also mechanisms like fluidics around the tube, immune mediated. Again, tube position can be dynamic, especially in a setting of low IOP. Sometimes you just apply a little bit of digital pressure on the eye, and a normally placed, a well-positioned tube sometimes comes anteriorly and touches the cornea. You really don't know what happens during eye rubbing and also blinking. Again, ocular hypotony is also a very important cause for progressive corneal decompensation, which has to be kept in mind. Next slide, next slide. Yeah, so I will just touch upon some of the surgical techniques that would minimize corneal complications, long-term corneal complications, GDD. Like, how do you optimize the length of the tube in the anterior chamber? How do you maximize the distance from the endothelium? Again, when do you reposition a tube and when do you trim a tube? Suppose corneal complications do occur. And very, very briefly touch upon sulcus placement and pars plana placement. Next slide. So I have put up a disclaimer here saying that the surgical techniques tips discussed here work well in our hands, and we would strongly recommend surgeon discretion to adopt, modify these techniques. Next slide. So there are two most challenging situations. One is tube exposure, another is tube cornea touch, which deter surgeons from truly adopting GDDs more frequently. So we found that burying the tube in the patient's own sclera in an adequate length and depth of scleral tract takes tube exposures out of the equation, especially in the pediatric age group. And then we found new challenges. Like it was difficult to position the tube deep in the AC close to the iris when compared to what you do with a short scleral tract. Next. So we position our scleral groove 2 millimeter medial to the original position of the tube. Next. We do some accurate markings on the sclera and also on the tube to optimize a 2 millimeter length of tube in the anterior chamber. If it's the right eye or the left eye, the scleral track is positioned medially. Next. So as you can see, the tube is draped over the cornea in the original position. Anterior bevel is made 2 millimeter from the limbus. Next. And then if you route it medially, almost always you get an optimal 2 millimeter length of tube in the AC. Next. And in this scenario, how do you maximize the distance from endothelium? It's also important to know that if you put a slit on the cornea, there's a slit that falls on the tube and there's a slit that falls on the iris. The distance between the slit on the tube and the slit on the endothelium should be maximized. As you can see here, there is hardly any distance between the slit on the iris and the slit on the tube. And this rule has to be obeyed right from the point of entry into the anterior chamber. Next. You need to find ways to make it work best in your hands. We did some markings on this 23 gauge needle and we found that this 2.8 to 3 millimeter is where this transition of the needle parallel to the sclera occur. 2.8 to 3 millimeter of the needle passes into the sclera parallel, and then at that particular position, if you suddenly change the position to iris plane parallel, you almost always, whatever the anterior chamber depth, minimal changes here, you almost always get the tubes close to the iris. Next. I have a small animation to show this. So this is your 4 millimeter scleral track. And that is your 23 gauge needle going in. As you can see, once the 3 millimeter is parallel to the sclera, you don't go any further. You lift up the needle and then that is your almost like your SICS entry into the anterior chamber. Next. So see this, there is hardly any space between the tube and the corneal slit. And this is prone for disaster. Next. Nowadays, we are most happy if we can get the tube on the iris. Even if there is a touch on the iris, all what you see in the long term, this is a 5-year post-op, all what you see is a small atrophic patch. We hardly have any post-op iritis or bleeding or any sort of complications. And long-term corneal survival, endothelial survival is maximized in this scenario. Next. So here is a situation where immediate post-op, everything looks fine. But as soon as I place a slit on the cornea and on the tube, I see this and I'm very worried. And in due course, there is progressive corneal decompensation. Next. The bottom line is you just cannot leave tubes close to the endothelium and you need to catch it early. If it's a focal corneal damage, you will have to reposition these tubes to a much, next slide, to a much posterior position in the anterior chamber. See this? There's a focal corneal decompensation, hardly any space. Next. So if the tubes enter the anterior chamber close to the endothelium right from the point of entry, you have to reposition tubes. Next. We also found that this initial sinuous route of tube implantation, nowadays, if we have to reposition tubes, we found that we no longer require tube lengthening procedures, which used to be a major headache earlier. All those tube extenders have, again, large hardware. And next. So this initial sinuous route helped us to reposition tubes in all tube-related complications without tube lengthening procedures. Next. Sometimes what happens is the tube is positioned well, it's close to the iris at its point of entry, but after that, the tube tends to become anterior and start touching the cornea. So this is where a tube trimming is indicated, and this is a much simpler procedure than having to reposition the whole tube to a much posterior location in the anterior chamber. Next. And this is particularly true in young children, somehow due to the elasticity of the sclera, no? Even though you get a very good entry right at the near the iris at the limbus, tubes tend to come more anteriorly with the elastic recoil due to the decompression, due to the lowering of intraocular pressure, and tubes tend to touch the cornea. Next. So it's very important that on table, you don't leave tubes close to the endothelium, especially in children. So here that is where that 3 millimeter, after the 3 millimeter needle is entered, and then suddenly you change the position to iris plane parallel, and we feel everything is fine. But as soon as we start entering the anterior chamber, we find that the tube is coming close to the endothelium. So never hesitate to make a second track. It's difficult to show three-dimensional, but believe me, this tube was entering the cornea, when entering the anterior chamber, quite close to the cornea. So you can make slight adjustments in your scleral track for the next track. For example, because this tube is coming close to the endothelium, you can see I'm going to dip before the 3 millimeter has gone into the sclera. So never compromise on the scleral track, especially in the pediatric age group. You can fashion this scleral track with the initial tube in place, and these are all self-sealing tracks. You don't need additional viscoelastic in the anterior chamber. You can suture, and so slight, even a 0.5 or a 0.3 millimeter difference is going to matter a lot. Again, the take-home message here is you just cannot afford to leave tubes close to the endothelium, because the long-term corneal problems become a major headache. It's a little tricky in the pediatric age group, but sometimes you might have to make a second or a third entry to get the tubes correctly in position. Next slide. Next slide. So I was looking at literature comparing sulcus placement with anterior chamber placement of tubes, and this is the best paper I found. This was from Ying Han, and it tends to suggest that tubes placed in the sulcus, the endothelial loss seems to be lesser with tubes placed in the anterior chamber. There are other articles also in literature referenced in this ophthalmology paper. Next slide. So in sulcus placement, if you have anterior pass, like in uveitic glaucoma or a post-PKPI, some of these developmental glaucomas like Axenfield, Rieger, or even for iridocorneal endothelial, tube placement in the sulcus is easy. Next. But we find it challenging in a normal depth. Next slide. Normal depth, anterior chamber, normal pseudophakic deep anterior chamber. Two tips here is to have your bevel posteriorly facing, but if you cannot have it completely posteriorly facing, you can at least have it a lateral so that the iris doesn't come and block your tube. Another important tip here is we want to see the tubes at least in the fully dilated position to make sure that the tube lumen is free. Next is a video. I'll just skip that video because of want of time. Next. Yeah. Coming to the last part, it's pars plana placement. Sometimes we have to even risk lens sparing vitrectomy if there's absolutely no space in the anterior chamber, like in this iridocorneal endothelial syndrome. Lens sparing full pars plana vitrectomy was required. Even a sulcus placement was not possible in this eye. Next. And also on a rare occasion when your cornea is very bad. Next slide, please. Cornea is very bad. Pars plana placement of tubes may be useful in tackling the refractory glaucoma. Next slide, please. It's also important to realize some perfectly placed tubes, the corneas can decompensate in the long run. Here is probably pseudo-exfoliation that is causing the corneal decompensation. Next. And you never know which cornea is going to decompensate. Next. So this was an accent field rigor. Again, tube flat on the iris, one eye completely decompensated, second eye even with a second tube, both tubes close to the iris, cornea is holding on for dear life. Next. It's also important to address ocular hypotony and treat it, and this could be a cause for progressive corneal decompensation. Next. I am not going to dwell upon this tube designs because I have no experience with the called glaucoma implant. But most important tip I would like to convey here is when you're dealing with refractory glaucomas in a setting of corneal problems where you have to preserve useful vision, risk a tube because corneas can be replaced unlike the optic nerves. Thank you very much once again for the opportunity.
Thank you so much, Dr. George Putran, for the wonderful set of slides and videos and so much of learning which you conveyed in your talk. Really very impressive. And questions, expert panel, Dr. Sunita, Dr. Gauri, Dr. Pandav.
I think it's always a pleasure to listen to Dr. Putran. And he visited shop, and we have also started for the last 2 years. We have started, putting the tube through a 4mm long tunnel, and we have never repented because the cause of exposure of tube basically is the micro motion of the tube. And when you put it in a sinuous way and through a tunnel, the motion of the tube is minimal or negligible. So I think, and the measurement and everything, I think is very important what he has shown, and he has given nice tips. I don't think we need to add anything more, and very nice videos and very good talk, Dr. Putran.
Very nice talk, Dr. George. I really enjoyed listening to that. And I second that sulcus placement, cutting the bevel backwards. So that if a particularly pseudophacos, it is, it is a single, it won't occlude the tube if the bevel is posterior. So if the iris is stiff, even side is okay. But then, as you said, preferably posteriorly, it should be cut. And wherever possible today, after having burnt my fingers quite a few times, if I can put it in the sulcus, I will put it in the sulcus. So that is what I aim for, more than, putting it into the anterior chamber. And your tips on the, when to turn the needle inside, the changing the direction, they were all very helpful. Thank you.
Thank you, Doctor.
Thank you. Dr. Arvind, are you back?
Yeah, I'm back. Very sorry for the internet disconnectivity. I don't
Can
know
you
why.
continue from where you...
Greetings, everyone. I'm presenting my video on a new innovation, glaucoma drainage device to drain the aqueous, which controls the outflow of the aqueous humor, which will prevent hypotonic and maintain IOP between 10 and 24/7 with no minimum need of anti-glaucoma medications. This is how OmniFlow tube looks. Minimum IOP back pressure is maintained by Bernoulli's principle, which essentially means that in a narrowing tunnel, the primary pressure P1 is proportionately resisted by secondary pressure P2. Minimum IOP of 10 mm of Hg is also maintained by another principle, that is anti or reverse capillary action, which means that if capillary is hydrophilic, it will attract and suck the water. But when the capillary is hydrophobic, it will repel the water back. Hydrophobic capillary wall tube made of Teflon will resist the aqueous humor passage, maintaining a minimum back pressure of 10 mm of mercury. Retrobulbar space behind the equator is almost free from myofibroblasts. Therefore, it is virtually free from fibrosis even without mitomycin C. Retrobulbar space can easily drain up to 500 microliters per minute without any involvement of proptosis or chemosis. Aqueous humor production and outflow discharge rate is only 3 microliter per minute. OmniFlow supply tube length is 50 mm and needed length is 30 to 40 mm. Axial length plus 5 mm is the ideal and enough length to reach retrobulbar space without touching the optic nerve head, without any folding, kinking, or overcrowding the retrobulbar space. Let's see few surgical videos of OmniFlow tube implant. So it is done under peribulbar or subtenon block. OmniFlow tube is anchored in sclera without any suture, and as seen in this video of failed trabeculectomy, the tube is so firmly secured, no matter how much we nudge, the tube will not budge. The tube is primed with 27 gauge hydrocannula and BSS solution, and the discharge of the aqueous humor is proportionate to the pressure which we are creating in the syringe. With low pressure, there will be no drops falling. With high pressure, there will be jet streams of aqueous coming out. And with medium pressure, only drops will be coming out. After putting an L-shaped cut in the conjunctiva and after little blunt dissection, insert a wire vectis to reach the retrobulbar space, which is very easy. And up to 40 millimeter of wire vectis can be inserted with ease, and it creates a smooth tract. Minimum and gentle bipolar cautery is done. After this, at 45 degrees and 5 to 7 millimeter away from the limbus, a scleral tunnel is made with 23 gauge angled MVR blade. This tunnel is properly lubricated with 2% HPMC OVD solution. The beveled end of OmniFlow is now inserted in and passed through the scleral tunnel. 3/4 of the length of the OmniFlow tube is pulled out, and the wall distal end of the tube is inserted into the retrobulbar space, which goes into the retrobulbar space quite smoothly and easily without any resistance. The excess length of the tube is pulled back and pushed back into the retrobulbar space. Now, a second scleral tunnel is made, which is radial or perpendicular to the limbus up to 2 to 2.5 millimeters from behind the limbus, which is then gently entered into the anterior chamber, bisecting the angle of the anterior chamber and the iris. Now, the beveled end of the OmniFlow tube is inserted into the anterior chamber via the second scleral tunnel. Care must be taken that only the beveled 1.5 to 2 millimeter and goes inside. Then the excess band of tube is pulled back and slowly pushed back into the retrobulbar space. After this, the firm anchoring of the tube is confirmed by vigorous pull, push, and side movements. In the end, fibrin glue is put over the sclera and conjunctival flap is repositioned and sealed. Entire surgery is of 10 minutes with no sutures. There is no induced astigmatism, so it can be implanted along with toric and multifocal ions. In this video, you can notice the decent anterior chamber depth. When the tube is in focus, IOL is out of focus, and when IOL is in focus, the tube is out of focus. So there is no hypertonic choroidal effusions or any hypertonic maculopathy. This is an interesting case of traumatic subluxation of crystalline lens with angle recession glaucoma and dilated pupil. The tube gets blocked by incarceration of prolapse with disc strands. Vitrectomy relieved the pupil blockage. The intraocular pressure came down, and so the mediatic pupil also became smaller. Post-RD surgery, silicone oil-induced glaucomas are extremely difficult to treat and are really intractable because of total blockage of collector channels by emulsified silicone spherules Mangement. OmniFlow drainage device can cure such conditions even after 2, 3, or 4 failed trabeculectomy. This is a case of double OmniFlow. IOP was around 100 in a one-eyed patient who had undergone multiple RD surgeries with repeated silicone oil injections with multiple failed trabeculectomy. OmniFlow is the surgical management of choice for neovascular rubiotic glaucoma. In this one-eyed patient of Stewart-Weber syndrome, after 4 failed trabeculectomy, OmniFlow saved the only working eye. In 23 patients, the IOP came down from 30 to 70 millimeter of Hg to 10 to 15 millimeter of Hg immediately after surgery. 18 patients maintained this level of IOP without any medications for a year. 4 patients required dorzolamide plus timolol combination eye drop, and 1 patient required 1 more tube placement. 2 patients of no PL gained vision of finger counting 1 meter to 3 meter after tube placement. This is due to constant IOP between 10 to 12 millimeter of Hg 24/7 without any night surge. The nerve fibers, which have recently gone dysfunctional and are semi-dead, can resurrect and are revived. So, in conclusion, OmniFlow will revolutionize the management of all types of primary or secondary intractable open-angle glaucoma, neovascular glaucoma, silicone oil-induced angle recession, posterior toxon, and glaucoma in a Suze-Weber syndrome in a most cost-effective manner. These are my acknowledgements. Thank you.
Thank you, Dr. Arvind.
Thank you so very much. And sorry, very sorry for the technical glitch.
That was a wonderful talk. Murli, could you take a question or two?
Yeah, I had a question for the panel and George sir. The OmniFlow seems to, not just the OmniFlow, all these A to B shunts seem to be very popular, but seem to be very effective. But why have they not been very popular? Like we hear of people talking about Ahmed walls, about RD, ACP, but we seldom hear anybody talk about this A to B shunts. And frankly, the last publication that I saw was, excuse my ignorance, but the last publication I saw was from 2012. So why have they not been so popular? Why are we still sticking on to the Barwell, the RD, the Ahmed valve? And why has the A to B or B to B shunts, why have they not been so popular as they should be?
May I take this question?
Yes.
Yeah. So I would like to tell you that 10 glaucoma surgeons, including myself, so we have operated more than implanted these A to B devices in 300 of the eyes. And the results are really good. If we think about these Ahmed glaucoma and the RD glaucoma drainage devices, they occupy a lot of space, right? And the side effects, the complications can be diplopia and the squint sometimes. And again, if we talk about trabeculectomy, so sometimes there is choroidal detachment and these hypotony. So these are not seen in more than 300 of the cases that we have operated by 10 glaucoma surgeons. Now coming to the publications, yes. So publications are there now started because our clinical trial is about to finish. So then only we can start with the publication part. But these are very effective and refractory glaucomas. Works very well. And now we have come up with the OmniFlow Supra, so that drains into the suprachoroidal space. So that also works very well.
How much does the OmniFlow cost and
so it comes in like packing like this, if it is visible, from Excellence Chennai. Is it visible?
Yes, yes.
So it's 8,000 plus taxes. I don't have any financial interest in this.
Any of the other panel members, George sir, have you tried these A to B shunts? What's your experience?
No. I think I haven't tried, but I think this is a very fascinating concept. I think Dr. Moore has really, I think, shown how it works. But I think the problem of the fibrosis still remains with that's there with all the drainage devices, because wherever you are releasing aqueous into the space, whether it's a subconjunctival, subtenon, or perhaps in this case in the orbit, at the point of exit, the fibrosis eventually happens. And that is happen. The same thing happens with the Zen implant. Where you are not actually doing any surgery. In Zen implant, the way you implant it, you're not doing any conjunctival or tenon dissection, but still the fibrosis happens there. So that's a natural response to excess aqueous in a given limited space. So I guess the same thing applies here also. So some of the failures are probably related to that, but definitely I think there would be uses. There are uses for all these devices, and I'm sure there would be uses for this Omni device as well. And I think the results Dr. Moore is showing is, I think, suggests that we need to we need to have more data basically, because 300 patients is still a limited data, but definitely I think we look forward to see the result of the trial that he's mentioning, and we'll have a little better kind of understanding after that. Yeah, but definitely we need some more procedures, different procedures, because we don't actually have a good, really ideal procedure for glaucoma.
True. Thank you so much. I know it's really late, but each of the speakers really excelled what was required from the topic. And thanks, dear expert panel, for being there and giving your most valuable inputs. and also the awesome speakers. And I'm sure those delegates who have watched today or who would be watching over the next few weeks would also gain a lot from this. Thank you very much. Thank you, doctors. Thank you.
Thank you.
Thank you very much, ma'am. Good night.
ma'am.
Thank
Good
you.
night. Good night.
Thank you. Good night.